for joining me today and allowing me to present for you the implementation of nurse navigation. This was to be a panel discussion, but Darlene Anderson from Emory University cannot join us today, so I'll be with you today. My name is Sharon Gentry. I am the program director for the Academy of Oncology Nurse and Patient Navigators. So I welcome your questions as we go through the chat today. I first want to start out with the why behind implementation. It's often asked, why do we need a nurse navigator program? Why is it important for us? Well, I want to ask you this question that I usually ask when I present this. Can you say that you do not have a fragmented healthcare system? Most people will say that their healthcare is fragmented. It's like a silo effect. Imaging's one place, oncology care is another place, surgery's another place. So I have to ask you that question. Do you really have or not have a fragmented healthcare system? And if you say yes, then absolutely this navigation program is for you when we look at nurse navigation. Understandably, I say here that patients do have questions about what to expect, what to do. And when you look at that nurse navigator, she's kind of pulls this together as a seamless system. She's a thread that pulls everything together. She can meet that patient before they come in, and then she can go with them all the way through the care continuum. So sometimes I get this question, so what's the difference in a nurse navigator and a regular nurse? A nurse navigator looks at that process all the way from the beginning of when the patient enters the system all the way through the end, through survivorship or end of life care. Is this necessary? It absolutely is. I want to share you about a new patient education that was done with oncology nurse navigators out in Utah in 2014. They met with their patients, and this was started out in breast oncology. They met with their patients before they come in and saw the medical oncologist. And so we found out from this study and others that meeting a patient early by nurse navigator is critical, and it can actually make a difference. They looked at their process of where a patient come in the system and how they get through it. And they realized by looking at the pathway that there was an opportunity for the nurse navigator to meet with the patient before they met with the medical oncologist. In this visit, they looked at the typical barriers of care that a nurse navigator would. A lot of them come up with financial barriers, but they also realized at that point that the patient didn't have their biomarkers or all the needed information for the medical oncologist to have a fully informed visit with them. And so they would get those things ordered, and then they would go and meet with the medical oncologist. When this took place, what they found out was it decreased the treatment time, which is our next point here, timeless to care, by 7 days. So it made a difference by knowing this patient, educating them on what to expect, starting to address some of the barriers to care, that they could do more timely care. But what is most interesting in our value-based care context today is the medical oncologists, and there were 4 in that practice, that after they were able to see these patients, they realized that it cut their new patient appointment time down by 30 minutes. So when you look at that with 4 medical oncologists, they were actually able to see each one of them one more new oncology patient a day in their practice because of the upfront work by the nurse navigators. In the end, when you looked at the cost savings along with the additional revenue this brought in, we were talking $485,000 a year that it brought in for this system. So yes, the why behind this is it can decrease the fragmentation. It can also add value to the system. And we also talk about timeliness to care. Nurse navigated patients, you can see here from a couple of studies I pointed out, can decrease diagnosis to treatment from 43 days, 11 days fewer than non-navigated patients. Now think of yourself as a patient going in a system. You want to get treated how quickly? And we're talking, we took it down to 43 days, and this was years ago. Also think about your readmission rates for your navigated patients. It was much lower, 9.8% for 30 days, 14.3% for 60 days. and 16.3 for 90 days. Often the why behind implementation may be, why are we seeing so many of our oncology patients come to the emergency room? Let's cut that readmission rate down. And I can share an experience when I first started a breast navigation program in the Piedmont area of North Carolina. When we got it established, we started noticing a lot of our breast cancer patients did go to the emergency room. And when we looked for a common trend, we found out that it was often on the day after their chemotherapy when they experienced what we call a steroid drop. The steroids actually would make them feel bad when they dropped out of their system. So when we realized that, education number one up front, you may feel like more achiness, a little bit not as well, might have had some increase in nausea after the steroids wore off. So we prepared them for that. Plus we said, please give the oncology clinic a call. Don't go to the emergency room when you feel that bad. And sometimes we relate it to like flu-like symptoms. So we wanted them to have a better access point. And so that was actually something that we did when we looked at improving timeliness to care and decreasing the emergency room visits. Here's a great question. Do your patients face barrier to access? If you have a fragmented system, yes. How about treatment? And what about support services? You have to talk to your patients to understand. Now, I call myself a dinosaur nurse navigator because I started over 2 decades ago before we had these wonderful resources I'm going to share with you today. But what I did realize when I started out that I asked the patient, and it was a breast oncology care process, number one, what did you like most about your care? And number two, what can we do to improve your care? Trust me, patients will tell you when they know how to get better care from a system, but we need to have their voice. And that follows into the next one, patient satisfaction ratings. We know when there's nurse navigator programs involved that there's often higher patient satisfaction ratings, but we need to ask them, remind them they're going to get a survey, also encourage them to be very open. Some people often use some family patient councils or little meetings, focus groups when you can start. And I'll explain earlier or explain later more about my process. But when we actually started back in 2000, the Nurse Navigator program for breast oncology care in North Carolina, we had focus groups for the patients. And what we found out is they did not trust our healthcare system. Really? We're healthcare. We're supposed to be trusted, right? Oh, no. And go back 2 decades. What do we know in breast care at that time? What they didn't understand was why Sally, that sings in the choir beside them, was getting a different treatment. Well, what about Mary next door? She didn't have to do her care this way. So them not understanding there were different avenues, different care pathways, it automatically built mistrust in the healthcare system. When they couldn't understand, they thought they were getting a lower standard of care than they should have at that time. So again, patients here are critical. And are you COC accredited? If you are COC accredited, you need to have a patient navigation process in place. It does not tell you what type of patient navigators to use, whether they're clinical based like nurses or social workers, or whether they're non-clinical licensed and just patient navigators that have been trained within the healthcare system to help people to get through the system. We know in coming years that COC is going to take a bigger focus on this, and they do not want to hear you say that you have a piecemeal approach. Social worker does this, clinic nurses do that. No, they want to see the unified process by someone that oversees that process to look at this. And many of you do a community needs assessment. So what is your community needs assessment saying to you? Is it telling you that your head and neck oncology patients are the number one population that does not complete their treatment? What about your rectal care patients? Are they the ones that never show up for the radiation or start radiation stop? Your community needs assessment, using all that wonderful data that's gathered in your hospital, can actually tell you the why behind implementation. And I also want to ask another one that's not on this slide. Are your patients getting standard of care? If you looked at the NCCN guidelines, could you say that all of your patients are getting standard of care? That they're having shared treatment decisions with what should be offered to them? Again, this is just some food for thought. Remember, we want to prevent patients from being lost to follow-up. We know that patients were facing challenges with care coordination, understanding medical terms, just knowing what questions to ask, and what resources are out there. And when I look back on this slide, I think about the word support services that you see there. In my dinosaur ages, when I started the program, I was also a genetic counselor that worked alongside our medical oncologists to help the people get the genetic counseling they need. We were able up front to identify those that need genetic counseling, and this counseling and results can make a difference in their surgical treatment shared decision making. As we went along, we gathered so much information to show that it was almost impossible to be a navigator at the same time to have that genetic component, that within 20 years, we had our own genetic department with genetic counselors. We had a manager and 2 other genetic counselors. But this all started when we started gathering information that it's right for the patients, but then you get to the point where there's a saturation load and the nurse navigator can no longer carry that as she should, and she needs to go to another professional focus and let them carry it forward. So the why resources, oh, how I wish I had these when I started my navigation program. I'm so excited to see a lot of you do. The why resources is we look at metric toolkits. And when we think at metric toolkits, I mean, I want you to look at the processes that are going along around you. I want to share with you that from the 2021 American Society of Clinical Oncology annual meeting, researchers presented the results of a retrospective study of real-world patterns of biomarker testing and targeted therapy for over 3,000 adult patients with metastatic non-small cell lung cancer. And this was in the community oncology setting. It showed that 23% of these patients were not tested for any biomarker in any time during the study, and that 49% had a biomarker test result prior to frontline treatment. That's standard of care. It's critical. It goes right into these metrics that we're talking about. The AONM Plus has Academy of Oncology Nurse and Patient Navigators has a navigation metrics toolkit, and it gives you a framework and identifies benchmarks that any navigation program starting out can automatically use. There's wonderful information here. It's tested in several settings, academic and community throughout the United States. They ask the question on, can we improve the patient experience? Can we improve the patient outcomes, the care outcomes, and the return on investment, the business aspect? And the answer to that is yes, that all can be improved by metrics that are being driven by Nurse Navigator program. Also under this same resource tab, we've done a crosswalk with all the national oncology standards and indicators. So you may be already gathering standards for QOPI, Oncology Care Management Program, or something like that. These metrics actually fit into that same. And so there's no use to redoing the wheel. You can use some of these metrics to prove the value of this program. Another why resource that you may want to look at is navigating the cancer continuum in the context of value-based care. It will show that there's many different models of navigation. You may have a navigator that does just breast. You may have a general navigator that does all the cancers in smaller programs. But you can, again, you need to look at what is your focus. Most critical is when you do a nurse navigation program, you have a start point and you have an end point. You have specific roles, specific duties that you do with that patient. And that can be well cited out in a lot of these resources. The whole idea is you want to drive continuous quality improvement. and value through evidence-based principles. And this is exactly what the Navigating in Value-Based Care can show you. Another one I'd like to add to your repertoire resources here is the Journal of Oncology Navigation Survivorship. The earlier study I talked about that came out of Utah that saved right under $500,000 for a system in 1 year was actually printed. So there's many more articles and there's many more things that you can tune into in the Journal of Oncology Nurse and Patient Navigation. So if you've seen one navigation program, you've seen one navigation program. One size does not fit all. And I think that's what's so frustrating, that a question that we frequently get on a professional level is, give me the blueprint to start a navigation program. We can give you the pieces. We can tell you what to look at, but you need to sit down with what's going on in your community, what type of setting you have to make sure that you have a program that fits. You'll see here that we asked you to look at a gap analysis. See it through the eyes of the patient. You may call it a patient flow or a clinical pathway, but number one, what are you looking at? All of your oncology patients? Are you looking at your head and neck patients? Where do they start in the system? Where do they go next? And what happens? And you can actually follow along with the patient, be very transparent in what you see, and it's wonderful to get their voice, collect their comments as they go through the program or the pathway. And then they say, why did I have to come on a Monday for this and come back on a Tuesday for this? And when you look and stand back and look, you thought both of those visits could have been completed in the same day. Or there's something that we need to do, be more proactive to take some burden off that patient. So you can look at this. I explained to you a little bit more about my story. When I started, I was under a wonderful program director of an oncology center. And also there was a program director for our local breast imaging center. These two had a vision that we wanted to improve care for the women in our community. In the community that I come from, it's a rural-based community, we kept our breast imaging center 1 mile down the road from the hospital where the oncology care was given. Why? The women in our community said, I don't want to come to the hospital for mammogram. You have horrible parking. It takes me a long time to get in and out. So purposely, our center for breast imaging was kept 1 mile down from the hospital. Then you had our 900-bed hospital where we had a lot of the radioactive, a lot of our imaging, other imaging services, a lot of our sentinel lymph node injections were done there. And then across the street, you had a more smaller surgical hospital. So you can imagine when I did my gap analysis and I followed the patient, and it literally took me a year when I started to kind of see common patterns to this. But remember, I asked the question, what do you like most about our care? What can we do to improve your care? As a navigator, you need to have a voice into something, and the voices are usually into your cancer committee, if not directly into your manager director. I did a presentation to our cancer committee. It's about 6 to 9 months after I started the program, and I said, let me tell you the voice of the patient. I am the messenger, but let me tell you what they were saying. They were so disappointed in our care. For a lady that come in with an early diagnosis of breast cancer, if she needed needle localization, she had to report to our imaging center 1 mile down away from the hospital on the day of surgery. She left there. She went to our 900-bed hospital where she got her sentinel lymph node injection. She left there and she went across the street to the surgical hospital where she got her surgery. When I told my story to the cancer committee, you literally could have heard a pin drop in that room. They were like, what? Often as healthcare providers, we don't think about it through the eyes of the patient and how they see that. I was very fortunate at that time to have one of the radiologists speak up and say, then we don't need this middle stop for this patient. We understand if they want to keep the imaging center away from the hospital, but we need to take our sentinel lymph node injection suite and go across the street with it to the surgical hospital. So again, it had never been thought about. Someone literally walked through that patient analysis with them. And this is the feedback that we got. It was also interesting at that time, we had a wonderful community support. If you have something that's working in the community, don't reinvent the wheel. We had a wonderful group called Cancer Services Incorporated, and they had a program called the Pink Broomstick Program. They literally, when they got a referral from, before I come along, someone in the hospital that said this lady had breast surgery and she'd like to see them, they would meet up with her and they would offer her the support groups that were there in the community. They'd also come into her home. And remember this 20 years ago, they would come in her home after surgery and teach her exercises to do. When the Nurse Navigator program started, we collected and started sending everyone with a breast cancer diagnosis that had surgery to this community program. Within months, they said, stop. We cannot handle the amount that you're giving to us. And so we sat down and thought they had wonderful resources for the Pink Broomstick program. They had wonderful support groups, and we didn't need to redo their support groups. They were working out well. So what we did at that time, we looked at the process and we come up and we realized we did a video of the exercises. We put a kit together that the nurse navigators gave to the patient before their surgery and one of their pre-surgery visits. And then we later trained the pre-surgical nurses to give that to them. And then after surgery, when the nurse navigator had let them know that the patient still wanted to see them and the surgery had been completed, they touched base with that patient 1 or 2 weeks afterwards. And so we revamped the whole community process, but we worked with the community to do that. What did it all mean for us? It meant more volunteers for them, more attendance at their support groups. It also improved our increase in volunteers at our cancer center. As people went through the program, they enjoyed the care they received and they wanted to give back. And it's been published in the literature many times that we can also decrease the time to start to the first chemotherapy treatment. Not only did the earlier presentation I talked about from Utah decrease their time to treatment, but when we looked at the way our patients were coming through the system, and we learned this from what had been done up in Johns Hopkins University, we saw that when that patient left from their surgical visit, we needed to have in their hand a follow-up visit with the medical oncologist. By doing that one thing, by just making sure there was a transition to the medical oncologist within a week, 10 days, even before if they needed to, we decreased our chemotherapy start time. And we know that starting chemotherapy earlier can make a difference in survivorship. So as you hear me talk about one size does not fit all, and you hear me talk about the gap analysis, we know that we can make a difference in the care as we go forward with patients over time. Here's some great resources I think that you would enjoy if you're looking at starting a nurse navigation program, or even if you're looking at revamping your program, you want to tweak it a little bit. Are we always doing the best we can? Team-Based Oncology Care is a book that was written in 2018, but I think you're going to be most enticed by chapter 4, Building a Nurse Navigation Program. It's all about building that program. What can we do about it? There's a book called Oncology Nurse Navigation, Transition into the Field. A lot of the navigators, nurse navigators, do start with oncology background. Some do not. So where do you go? A book that was written many years ago by Lily Shockney is called Becoming a Breast Cancer Nurse Navigator. Those of you that may be looking at a GI program, a head and neck program, you can still read this book and get basics, especially a wonderful overview of a gap analysis. Oncology Nurse Navigator, Delivering Patient-Centered Care Across the Continuum, is its second publication, and it's a wonderful book, again, that has resources. The other one, Equipping the Nurse Oncology Navigator, an ONS collaboration with the Academy of Oncology Nurse Navigators, was created in 2019, and it was a wonderful course that you can take. There is a fee for this, but it's well worth it. Gives you lots of tidbits, gives you a lot of interactive videos and information on how you can create a program. And if you want to just know the fundamentals about patient navigation, the George Washington Cancer Center still has a wonderful program on oncology patient navigation fundamentals, all about training and all the basics of navigation. I'm going to take some of your questions, but just let me point out one pearl of wisdom to you. With all the health inequities that exist and were brought to the forefront by COVID-19, patient navigation was identified as a patient-centered intervention that functions across the care continuum and addresses cancer disparities. AONM Plus come out with it, a cure clinical trial, and you can look that up, ACCURE clinical trial. It showed that navigation, working within a hospital system with your electronic health records, can take your healthcare disparities down to 0. It can be done well with a team approach. The development of an actual framework to address cancer care disparities in the medically underserved population in the United States shows navigation is the key. This was supported by the National Minority Quality Forum, Longevity Foundation, Cancer Care, Fox Chase Cancer Center, BMS Foundation, and the McMary Vanderbilt Alliance. So yes, it does make a difference. All right, Dana, let's see what questions that we can answer right quick that we have going on here. How did you initiate the Navigator program to your hospital? Again, I think I explained that by showing it come out of focus groups that we did in the community, not only with breast cancer survivors, but women in the community that were concerned about breast care. And maybe it was family members of those. We had to get all the teams involved to help improve the flow of patients. So it's critical to have a champion. I was lucky to have 2. The director of the Oncology Center, as well as the director of the Breast Imaging Center. They stepped up and they were wonderful for me. So that was kind of my outlook today for you to how to initiate a Nurse Navigator program. Thank you for joining me today. And we look forward to presentations in the future. Thank you.